turnout of almost 900 attendees registered for today, which is really a record-breaking number for our series. So thank you all. We also want to acknowledge, we know there were some issues with the calendar invite for today's event. So we really appreciate everyone, all their effort in making sure they're here today at this right time. I am Andrea Graham. I'm the co-director of the Center for Behavioral Intervention Technologies, or CBITS, and I'm thrilled to welcome us back for our Reimagine webinar series, The Future of, where we bring together thought leaders across sectors to explore some of the most pressing issues shaping the future of digital mental health, from AI to policy and regulation, the power of partnerships to the next generation of investigators. We're asking experts how we can turn potential obstacles into opportunities. Today, we are very fortunate to be joined by Dr. Shannon Wiltsey Stirman, who's going to be presenting the future of AI and implementation science. So I'll introduce Shannon in just a minute. Before I do, I'm going to mention today's webinar will be recorded, and it's later available for viewing on our YouTube channel. I know that's often a good question people have of can they review the recording later. So yes. And at the end of Shannon's presentation, we'll have some time for a brief Q&A, so you can use the Q&A button in the webinar to ask questions. And we'll do our best to get to as many of them as possible. So without further ado, I'll introduce today's speaker. So Dr. Wiltsey Stirman is professor in the Department of Psychiatry and Behavioral Sciences at Stanford and a psychologist at the National Center for PTSD's Dissemination and Training Division. She's co-director of CREATE, an NIMH-funded P50 alacrity center that focuses on using large language models to support implementation and access to effective treatments. She serves in leadership roles in Stanford's Mental Health Innovation and Technology Hub and in AI for Mental Health Initiatives. Is a leader in so many areas of research. We're thrilled to learn today of implementation science, evidence-based treatment for PTSD, depression, and suicide prevention, and use of technology to support access to evidence-based interventions, with research funding from NIH, the VA, Query, private foundations, and the Canadian Institute for Health Research. So we are so lucky, Shannon, for you to be here today. Take it away.
All right. Thank you all for having me today. And I'm going to focus primarily on using AI and large language models to support implementation. And one of the reasons that I got interested in this is that some of the early use cases for large language models seemed like they could be particularly good fits for some of the things that we do to support therapists and to support administrators and other folks who are working on implementation efforts. But I also want to just highlight that this is a time where large language models are also giving us opportunities and the associated risks with going straight to consumer. So if we think about what we're trying to do with implementation science as improving access, I think we have to look at the writing on the wall, which is that people are going straight to AI for therapy now. So this is something actually from a couple of years ago. There are Reddit subthreads on how to prompt ChatGPT and other large language models to, just to act like a therapist. And in a study that we have under review, we tried to get kind of a nationally representative sampler, as naturally representative as you can get on Prolific, which helps us to have verified identities of our participants. About 24% said that they had used LLMs for mental health. And some other estimates have been even higher. So that's something like 18, but somewhere between 18 and 40 million people have used LLMs in this manner. And if you look in app stores and look for AI therapist, you'll see pages and pages and pages of AI-based tools that do something, something mental health, wellness, emotional support focused. So, we're already seeing that people are using these. People are seeking out low barrier ways to get access to effective care. And there's a lot of interest, both academically and in terms of investing, venture capital, et cetera. And because of the kind of challenges to the regulatory landscape, what we're seeing is that there are a lot of things that are kind of being framed as wellness tools that are essentially doing mental health intervention. One of the challenges, though, is that if we ask these tools to take an evidence-based treatment and give us an example of what it would look like. So this is something I prompted a bunch of different chatbots like Gemini, GPT, Claude, etc., and asked it to give me essentially like a sample transcript, or some of them wouldn't do that because they said, oh, that would be a HIPAA violation, even though I said it, a sort of an example so I said, write a very realistic script for a therapy session. And if you don't know the therapy well, you see a lot of things that look like the therapy, but they're in the wrong order. They don't include certain elements. They include elements that should come much later, much earlier. It's kind of a mishmash. It's sort of like um, just a mix of things that sound plausible, but really don't represent the therapy done well. And I think that that's basically what LLMs are designed to do. There's a lot of questions around, are they actually thinking? What are they doing? Do they understand? But in essence, they are predictive models. And there's more complexity to it, but in a very simplified way, they are doing essentially what your word complete does if you Google and it gives you suggestions of how to finish the stem. It's finding the words that are, most closely associated with your prompt, and they're kind of organizing them and giving you responses, and they can be quite good at it because they're trained on so much language. But what they're not trained on is therapy transcripts. They don't have a lot of examples of good therapy. So when we think about developing these for mental health intervention, the out of the box, kind of general purpose large language models just really haven't been trained on the type of data that would get you high fidelity, good quality evidence-based treatments without some additional prompting, without giving more examples of what good therapy looks like, et cetera. So that's something for us to think about because, um, there are debates on what a therapist does that an LLM can't and vice versa. Um, but in the meantime, this is something people seem to be seeking out. And I think more and more, the front door to the healthcare system is going to be things like, for a long time, it's been people searching the internet, right? Like I'm depressed, or I'm panic, noticing that I'm having more panic attacks. What do I do? That's been going on for a while. The difference is, instead of a Google search giving you, things that you can read through, now you're getting actually an interactive response. So I think we need to be attending to this and really thinking about what we can be doing to support quality and very careful evaluation as these things develop. And so one of the ways that we've been thinking about this at the Create Center, which I'll be telling you more about in a bit, is how to integrate large language models into psychotherapy effectively. And the analogy that we've used and others have used as well is a self-driving car. So I've been living in the Bay Area since 2015. And when I first got here, you would notice people driving around in essentially a Waymo, an early prototype of a Waymo. And there would be somebody in the driver's seat and they'd be driving, but it would be collecting all of the data. And then over time, you started to see someone with their hands off the steering wheel, but ready to override very quickly if they needed to. And now we're actually at a point where we have autonomous cars driving around in this area. So, but that's taken, more than 10 years. And even before that, there was a ton of training data that was entered into these. And so if we think about psychotherapy in a similar way, this is a similar high stakes. If something goes wrong, there could be, catastrophic results. We need to sort of think about it as, first, it's very much the clinician is in, the AI is in the loop. The clinician is really in the driver's seat. And what we're doing is offloading small tasks. So these could be things like the large language model drafts clinical notes. And then at some point, we might start having the clinician supervise larger tasks. So this could be things like a large language model could provide guidance on homework. the CBT worksheets that people are doing between session. The LLM could actually be providing some feedback, some guidance, but the therapist could be looking at a dashboard, quickly overriding if if something goes wrong, if the advice is poor, if it's not helping, if risk is detected, et cetera. And then at some point, we might get to a point where we see fully autonomous treatment where there's, an LLM does the assessment, selects interventions, continues to update based on case conceptualization and data on how the client's doing. But we're quite a ways off from that for a lot of reasons. So we've been really working more on the kind of AI in the loop and clinician in the loop. Just as an example of kind of where the field is right now, some healthcare systems have been rolling out AI clinical scribes and different documentation tools. So these are essentially summarization tools. They might be embedded in an electronic health record. They might be things where a clinician kind of records the session, uploads it, and then gets a structured summary. Or, it might be ambient listening. But this is one of the first places that I think we're starting to see implementation of AI. And this is really something that can support clinicians, give them less time documenting. They would just review the notes, make changes, and then approve them. And once we remove the time for documentation, that could be, hopefully that will reduce burnout. I know there are questions about whether it'll actually increase productivity. That might not be our optimal goal. It might be much better to think about improving quality. And once we have this ambient listening, there are opportunities like doing fidelity assessment along the way, providing, clinical support and guidance. And there are still some risks. So there are some things that we need to be thinking about that haven't been fully refined. And so this is evolving, and I think notes for mental health, I think, are rolling out more slowly in large healthcare systems. And there are questions about what do you do with the recording afterwards? How long do you keep them? So this is an implementation challenge in and of itself. My sense is it's being adopted a little bit more freely in private practices because there's less, there are fewer issues around compliance, et cetera. It's being offered maybe as part of packages for some of the softwares that clinicians use. So this is really one of the first use cases. And the second, in part, potentially through leveraging, some of the ambient listening, are opportunities to do things like supporting therapist training, supporting quality, fidelity assessment, fidelity support. And this can be through things like automated coding. Listen's been doing this, looking at fidelity coding. There's really progress being made even before large language models with natural language processing methods to assess fidelity. But then they can also provide feedback, very quickly after a session or potentially even in real time. And then additionally, large language models are good at things like simulating clients. And so you can actually have simulated interactions where you practice before you would even start, actually seeing a client. So if you're learning a new treatment, or let's say you're learning safety planning or, management of suicide risk, and you're potentially working with high risk clients. And if the first time you ever do it is when you're in a room with a client, that's not ideal, but it's very often how it happens, or maybe some small role plays. The simulated client interactions actually give you an option to have a full interaction, or even multiple sessions worth of interactions, and get real-time feedback or very quick feedback to do things like start over and try again, or try out different approaches, to sort of find your own voice while using the best practices. So I think there are a lot of opportunities here. And then when we get to automated treatment, there are some consumer mental health chatbots. Now, these are still actually therapist in the loop. I wouldn't say that these are necessarily fully autonomous. There's monitoring and things going on in the background, or they're hybrid models. But there are a couple out here. Wobot was an earlier one. They are not LLM driven, and they've actually been, I think, kind of the regulatory pathway wasn't really clear for them. WISA, I think, is still operating. And then there was recently, in the last year or so, a randomized control trial of a CBT large language model. This was the first fully powered RCT of a chatbot. And this is from a group at Dartmouth. Actually, Nick Jacobson's going to be talking, sharing at Grand Rounds later this week at Stanford, and then doing it at a webinar with our tech hub here to kind of talk about the development and testing. But this is with a group who had clinically elevated but mild to moderate symptoms of depression, anxiety, or risk of eating disorder. And it was compared to a wait list. But it was a good demonstration that people could improve. Folks did better than the wait list. They didn't have large safety issues. And this was actually trained, that the chatbot was trained with over 100,000 hours of I think therapy transcript, not real therapy transcripts, but generated lots of examples of what good therapy would look like under these circumstances. So I think where we are right now is if you think about general purpose large language models, like the ones that you can just, access, GPT, Gemini, Anthropic's, Claude, et cetera. These really aren't built for clinical use. How the data are used are they don't have the same privacy restrictions, et cetera. They're not used under a business agreement, if you're doing therapy. So if somebody just signs on and starts using it for therapeutic purposes, it could be used to train the model. It's not, the safety guardrails are getting better for some of these. And, we've seen some of the high profile lawsuits, et cetera. But they are not, this is an area where they're still advancing, and they're not, the FDA would really not allow them technically to be intervening, on mental health, versus purpose-built clinical AI, which is, more domain specific. It's been trained with good examples of, and a lot more fine tuning, so that it can perform better in terms of offering high quality therapy. Should be HIPAA compliant. There should be a business agreement signed if it's going to be implemented in a healthcare system. It would be, there would be more safeguards in place, et cetera. So these are not, these are not really being widely rolled out yet, in part because they haven't been, tested very much. But these are just the difference between the two. And what we know so far, this is something that a paper that Betsy Stade is leading that we have under review, but we've been looking at using things like APA's professional practice guidelines, and really thinking about, what are therapists supposed to be doing in practice, and which of these things can an LLM do and which can they not do. And so, large language models can approximate, sort of cognitive empathy. There are some studies that show that people find them to be empathetic. They can deliver psychoeducation. They're available 24/7, which is not something that therapists are. They can identify things like linguistic markers of distress, and they can follow manualized protocol scripts, et cetera. They could do some skill coaching, those types of things. What they can't do are, things around genuine therapeutic alliances, although measures of digital alliance look quite good for them. There aren't really systems yet that are rolled out and fully tested that, read nonverbal cues, et cetera. Clinical judgment in ambiguous situations is an area we really have to think about. What it means to navigate rupture and repair as a chatbot versus a therapist, and the impact that might have in terms of someone's functioning, relationship functioning, et cetera, is important. And then, I think we also have to think about, one of the important things that clinicians do is we operate from a set of ethical principles that is different than what a chatbot is doing. And so we really need to think about what that would mean, and how a chatbot would adhere to what ethics they would need to adhere to, ethical codes, et cetera. So these are some of the things that they can and can't do. And, because the FDA has not really approved any of these for general use, because things are still being tested, what we are seeing is this kind of wellness loophole where a lot of unregulated and untested chatbots are out there, in the App Store, et cetera. And so far, they're kind of doing this without approval, although we are seeing the UK just removed some from the App Store. And we are seeing some pushback about this. So one of the things that we'll be doing at Create in the next month or so is having some folks with a lot more knowledge and expertise about the regulatory pathways where the FDA is. They'll be speaking in one of our webinars about this area. So I want to tell you a little bit about what our center has been doing and kind of where we've landed right now in terms of doing work to support access to and implementation of evidence-based therapy using large language models. So this is a P50 that was funded last August, and we're starting out with a focus on PTSD treatment, but broadening, very interested in broadening as well. We kind of started with PTSD because of where we're situated and some of the expertise that we had on our team and some of the problems we were trying to solve. But some of our key aims are to develop tools to support implementation of evidence-based treatments in public mental health and under-resourced settings, evaluate the tools, and then, as a P50 center, we're also trying to support, provide resources. And so this is our team. And we had a recent, we had a kickoff last November, so we're really in pretty early stages. But we are working with a number of community partners to do our user experience interviews. We'll be doing some testing and, through some of these partnerships. And really, we have 4 tools that we're creating and testing, and then these kind of align with the 4 main projects that we're doing in Create. So we're thinking about this as supporting implementation throughout the pipeline, starting from implementation support. So we've prototyped, but are not sort of in very early stages of developing what we call the implementor. This is support for implementation planning for systems and clinics and programs that might not have access to implementation facilitators or, some of the implementation supports that have been tested. And the goal is to help people, help them develop an implementation plan, working with a team to develop an implementation plan and to help them troubleshoot as they try to execute the plan. We've also developed and started testing Therapy Trainer, which will provide simulation and feedback for therapists who are learning new treatments. And then we have one called Coach AI that'll be providing on-demand consultation. So beyond maybe that initial consultation that people get when they're first training, we wanted to have a way for people to get on-demand support whenever they needed it, right after a case. And we're looking at whether we're going to integrate that right into some sort of, ambient listening for documentation, or whether it would be more of a, reach out to Coach AI when you have questions. We're working with end users and kind of trying to ask those questions. And then finally, at the time that we submitted the grant, and I think maybe still the case now, NIH was not quite convinced that the direct-to-consumer was, ready. Direct-to-consumer approaches would be ready for prime time. So we are focusing on something that supports clients between therapy sessions by basically helping them and giving them some feedback on their homework, on their between session practice. And then we've also been looking at things like, we have some other projects in the works, but this is sort of the original grant. And so you can see that we have different target users ranging from therapists to clinical administrators. We're looking at different treatments, including one non-trauma focused treatment. And we're using some different common methods and frameworks to do this. So we drew from actually the UW's Alacrity's DDBT process to really, take these things through development to testing. So lots of interaction with end users, lots of effort to try to understand the whole context, to make sure that we're developing and designing something that will work in context for the people that we are designing it for. And then we're also using the NAS framework as kind of our implementation framework. And then we're working, of course, the foundation models that we're building these from are improving all the time, but we need to be able to, the LLMs need to have a big enough context window and have ways to actually track progress. They need to have the domain, the foundational information. They need to be intuitive for users. And one thing that we're really focusing on is tapping into mechanisms of change across these and making sure that we can both assess and activate different mechanisms of change. And for all of these, even though we have different target users, there are things like, learning, reflecting, developing skills in different ways, and increasing motivation. So just to give you, a sense of what implementer will look like. I mean, it's going to look more like a chat bot, but and hopefully it'll make a much prettier implementation plan. But it would develop an implementation plan with people iteratively. And one of the things that we learned when we first prototyped it is if we're not careful, it'll ask the questions that we wanted to ask about context and gather some information and then spit out an implementation plan that might actually look pretty good. But, we really think that in order to engage the user and have it be something that they're invested in, that they really believe will work in their context, it's really important to have much more back and forth and have more of a sort of a discovery process that engages the user more. So we're developing that. And then the idea is that there would be regular check-ins and ways to really troubleshoot once they get the plan. For our second project, Therapy Trainer, we've done some initial research. We developed a platform. First, we developed the simulated patient personas and scenarios to make sure that they were realistic representations of people with PTSD who were going to use written exposure therapy. So we worked with trainers and clinicians, since the target audience is going to be clinicians who are learning this treatment. We introduced it into a training. We did a mixed methods analysis and did some user testing. So that was our first phase. And this is just what the original prototype looked like. We've now made some changes so that, but people can talk to their AI consultant and ask questions. They can interact with the chatbot and then get feedback as they go. And they also have sort of a fidelity checklist on the left that we're working on sort of developing. Well, we've actually made some progress in assessing fidelity as we go so that we can make sure that we have a validated, grounded fidelity measure. So we also have some other things like places where they can build specific skills, like intervening around suicide risk, responding to the trauma narrative, and some of those things. And so the therapist feedback, at this point, we've probably interacted with, the initial study was, I think, about 17 people. And now we've interacted with a lot more people and done a lot more refining and user experience interviews. But some of the things that people appreciated were being able to interact with it in multiple languages. They liked getting really targeted feedback in real time. And then there are some things that we've been refining based on some of the initial feedback that they provided. So Coach AI is an effort to give therapists ongoing support, which I think is really important because we've seen some studies that suggest that after initial training, fidelity erodes fairly rapidly, and that we really do need ongoing support. But this is often a pretty big burden for healthcare systems. It's not accessible a lot of times to clinicians in private practice. So Coach AI is intended to give people ongoing support. And then the worksheet helper interfaces with clients. We're actually integrating it into a research version of CPT Coach. And so this is just a wireframe from an earlier prototype where the AI would give feedback similar to what a therapist would give in session if somebody were working on a worksheet. And the idea is if we can give them some support and working through it in between sessions, maybe they'll get more work done because they won't feel so stuck. And maybe they'll make more progress and improve more quickly. So we are working on building this. Both Therapy Trainer and Worksheet Helper are going to be tested in Worksheet Helper will be a pilot trial. We're hoping to start this fall. And then Therapy Trainer, we're doing a fully powered randomized controlled trial starting this fall as well. And we'll be doing some more pilot work with the whole platform probably middle of summer. One thing that I mentioned earlier, and I want to just say a little bit more about, is that, one of the ways that we want to sort of distinguish what we're doing at Create is really making sure that these are grounded in, fidelity assessments, that they're actually targeting and detecting mechanisms of change. So this is kind of a busy model just to show that, each of these, we have some outcomes that we'll be looking at, implementation outcomes like reach, satisfaction, acceptability, clinical improvement for everything except for, I think, implementation helper. We're mainly focused on things like reach, acceptability, and satisfaction for that. But for each of these, we're going to be looking at tapping into and increasing motivation, engagement with the tool so that, they use it enough to get sort of an effective dose. And then that it gives people opportunities to reflect, experiment, plan. These are sort of the three things that we're hypothesizing to be mechanisms of change that lead to improved skills and then cognitive change, whether that's self-efficacy for the therapists or for the leaders who are using implementation helper, or cognitive change at a clinical level for the patients using worksheet helper. The implementation framework that we chose was the NAS, and this is really designed for technology implementation. So these are some of the domains that we're assessing in our our preliminary interviews and as we collect data. So things like characteristics of the adopters, how people perceive the technology. In the grant application, we call these magic tools. We now call them create tools. The healthcare, characteristics of the healthcare organizations where they'd be implemented, as well as the wider system. So certainly regulatory issues are a factor in this. And, we're already kind of trying to navigate questions like, is Coach AI decision support? Does it meet some of the criteria? At what point does this become something that falls under FDA guidance? Probably, implementation, implementer won't be clinical decision support. The therapy trainer is really just training. But then, the other two are either patient facing or, supporting clinicians. We're thinking of Coach AI more as an educational tool, but we have to see how that aligns with the way that the FDA ends up really thinking about this. So I think that the system issues are going to be things that we really need to attend to. We also have a framework to evaluate readiness for implementation, and these were sort of grounded on some of the APA ethical, some of the ethical principles from APA, but things that we think really need to be evaluated before they could be rolled out into clinical care include safety. And this is just really, it doesn't promote dangerous behavior. The interactions aren't psychopathological, the flirting with clients or encouraging harmful behavior. And even things like not doing a full assessment before making recommendations. I mean, one of the early sort of high publicity places where chatbots went wrong was in the Tessa tool for eating disorders, where it apparently started giving dieting advice to people who were struggling with eating disorders. The dieting advice might have been perfectly sound for some people, but was contraindicated for some of the users that this tool was really targeting. So we wouldn't want to see that happening. Privacy and confidentiality. We need transparent, plain language data use policies, real opt-in and out choices for users, notification protocols for breaches, safeguards for patient data. And then we need to attend to equity. So we need to be working to, minimize and remove bias in terms of the way that the chatbots communicate, that there need to be culturally appropriate responses, whether in terms of coaching the therapist or interacting directly with the user. And then also that we see, similar levels of effectiveness, engagement, and satisfaction across different demographic groups. Certainly effectiveness, these things need to be carefully evaluated. Engagement is an interesting one because we need to make sure that they are appropriately engaging. We want to see that they're engaging enough for there to be an adequate dose, but not so engaging that they breed some sort of a dependence. And so that's something that I think we need to be doing careful evaluation around. And then readiness for implementation. We want to see these developed in such a way that they can integrate into regular, real world workflows, clinical settings. And that, things like all the compliance issues, that technology is built with an eye towards being able to easily implement into systems, but also being aware that a lot of times they're going to operate outside of systems. The direct to consumer may or may not be integrated into a healthcare system, and the direct to clinician offerings, similarly may or may not be implemented in a system. But we need to be thinking about this so that we can really sort of speed the pipeline for implementation. And so these are some of the key questions that we would be asking. Recently, Richard Gauss led a scoping review and found that very, very few, none of the tools attended to all of these, the evaluations of AI mental health tools. None of them really looked at all of these. And most of them were looking a little bit at effectiveness, although many of them weren't using validated measures. And looking at safety, but some of the information about, things like privacy, engagement, et cetera, really are not explored well. So, but we think that, these are all key questions, not just questions around safety and effectiveness, but we need to be thinking about all of these to really make sure that they're implemented in a way that they can help the most people. Just a couple more pieces of information about what Create Center is doing as some of the different things that we're doing. Our website is going to be, we have different tools. We have a curated set of readings that I'm trying to keep up with. This is a field that moves really fast. I've got to update it, but it was updated a month or so ago. So we're putting out some different readings and things that we think are relevant papers in this particular space. We'll be, providing open source code and, information about all of our papers. We are providing mentorship and support to early career professionals. We have a pilot program. We'll be making an announcement and sending out an RFA probably late this summer for pilot funds. And we have a webinar series every month. Some additional products that we've been developing and working on are just investigation of naturalistic large language model use, trying to understand how people are using them, how they're kind of behaving, how effective they are, at least, what types of things are they doing that are associated with change? Are they appropriately attending to things like safety? Are they using evidence-based methods? Are they trying to do therapy? Are they referring people for other help? And then how the users really think of them. Are they using them in addition to therapy, instead of therapy, just to get information, et cetera? We're also, we've made some progress on using large language models to detect treatment fidelity for written exposure therapy. We've been looking at using simulated therapists and developing something to actually have an LLM guide written exposure therapy with a human in the loop. So there would be, a behavioral health tech or a therapist in the room while this was happening, but the LLM would be providing the guidance. And then also we're looking at it to support things like single session intervention training with some collaborators at Northwestern, actually. So these are some of the projects that we're that are in development. We're in kind of earlier stages with. And if you want to learn more about what we're doing, I have some different ways to get in touch, including our website, contact list, if you want to check out some of our webinars. And then we also have a lot of opportunities for user testing and feedback. So we'd love to hear from people who are interested in providing feedback. So let me pause now. We should have a lot of time for questions and discussion, and I'm happy to go deeper into some of the other, any of the information that we've provided here. So I will pause and see what questions are coming up.
Thank you. That was amazing. Such a broad, fantastic overview, and it's really exciting, all of these projects. Getting lots of emojis coming through the chat too. So we have some questions already. To folks in the audience, please feel free to submit others. A quick question, which I loved, you'll see why. Can you share more about what you mean when you refer to assessing for fidelity and fidelity measures?
Yeah, yeah, absolutely. Um, so we've been trying to figure out, and I will say, adherence is a little easier to deal with than competence. But we've been trying to use the large language models. We also have some transcripts from a study that we recently did with Talkspace of messaging-based therapy. So for that one, we're looking at using large language models to assess, whether the CPT protocol was used, how much of it was used, et cetera. In addition, with the written exposure therapy protocol, we've first been looking at adherence. And actually, there's a language-based approach that doesn't involve large language models, which means you don't have to send the data up into the cloud. It's more secure. But that seemed to be outperforming large language models. So that's something that folks in our group have been working on. So for adherence, we're really looking at, can we detect how much of the protocol has been developed? Then we'll move into how well is it being completed, and that is a little more challenging if we're using large language models. I think, there are NLP approaches where you use, you train it on lots of transcripts that have been labeled, that have been coded. And this is something that Listen does. They do have competence measures for CBT and motivational interviewing. We're trying to figure out, whether we can use large language models for these. When we first started, they really weren't good at, they could do kind of a thumbs up, thumbs down, this is a good example, this is not a good example, but kind of those, everything in between. I think they might be getting better, but we've been tackling adherence first. But we do want the feedback that we provide to be grounded in, we want it to be actually grounded in measures of fidelity rather than a kind of impression, or the chatbot kind of reacting to the language. So we're trying to use those, we're trying to develop those because that opens up a lot of opportunities for, either possibly, real time nudges or, support, depending on how, if you're doing telehealth, there could be a way, and this is something that I think we'd have to really get end users input on. But is there an unobtrusive way where, just some little reminders or supports could be, somewhere up on screen? If people don't want that, it could be that after the session, they get pretty immediate feedback. Maybe not just a fidelity score, but some recommendations on, what to do or things to target in the next session. That would kind of align with the consultation on demand, goals that we have. But I think that, when you think about how we were doing training, even a few years ago, it was really, you do training, maybe you have a consultation call. If you are reviewing recordings of sessions, you have to upload it somewhere. Somebody has to listen to it. They give you feedback. That's, obviously it's not scalable. And it takes time, right? Like by the time you actually could meet with your consultant, if you were in a really well-resourced training program, by the time you could meet with your supervisor or your consultant, it might be many days later. Maybe you've even seen the patient again. And so now being able to just do this real-time fidelity assessment, I think, has a lot of implications for, improving quality and really making that accessible to a lot more clinicians.
Thank you. It's so exciting. Um, Questions about safety. So how we can move forward. There's two questions that I'll ask them together. How we can move forward safely. What does it currently the landscape look like for solving these privacy challenges? Any insights on how we can do this while staying within our code of ethics, as you started to get at? And relatedly are you training these models on sensitive data? Are you using de-identified data? Those are the questions. Stu, I see you raising your hand. You won't be able to come off mute. So if you could put it in the chat, that'd be great. Thank you.
Yeah, yeah. So, so far, we have not trained we haven't been training these with sensitive data yet. We've been, we've been looking at adding some data. We do have transcripts from, previous studies, some of which have, data sharing allowed, et cetera. But we are trying to be really careful about this and thinking about, when people agreed for data sharing, could they have imagined that this is what we were talking about? So we're looking at, but also, I will say that there are some challenges at an individual level, like you can develop some individual simulated patients that that can look like, the types of people that you would see in routine care. At scale, though, I think there are still some questions about whether they really behave the way that sort of the full range of people you'd see in clinical care do. So, we are really evaluating the best ways to, train the models with examples of, this is what a realistic client would look like. It gets a little bit easier on the therapist side, to provide examples. You don't need, with NLP, you needed, hundreds or thousands. With large language models, you don't necessarily. You could give it, maybe 10 or 20 examples of high quality responses to certain types of prompts or things that the client would say. So at this point, we're not actually training the model on sensitive data, but I think when you start testing, more at scale and really, really trying to look, especially the worksheet helper, and I want to just acknowledge that there are people on our team who know this a lot better than I do. So the answer I'm giving you is, like I know enough to be dangerous, but we do need to think about like a large number of different interactions to really test it to be confident that these interactions are safe. And we have some colleagues, one of our CREATE investigators at Rush University, he and his collaborators and team have developed something called Astra, which is looking at ways to make sure, to detect and label kind of the toxic chatbot behaviors and, looking at minimizing them. One of the things that we do that is important when you develop these is really a multi-agent approach. Where you would have, multiple chatbots kind of working together behind the scenes. So there could be a fidelity monitor one, there could be a safety monitor. You'd have a number of them that would be kind of detect, doing their jobs behind the scene and then feeding the information to the one that actually interfaces with the client. So I would say we're in earlier stages. A lot of the safety testing, if, in kind of trying to keep up with the literature on this, one of the challenges right now is that some of the safety testing that's being done is really with like single iteration or very brief interactions with the chatbot. Particularly if you're working, if you're trying to look at what consumers would do with a chatbot, is, these things go over months, right? So it's not just, I have a gun in my home and I'm feeling suicidal, which most chatbots do a pretty good job at dealing with. It's something like maybe some of that information happened like 6 months ago, and the context windows of these chatbots are not always large enough to maintain that information, right? So making sure that that over many, 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 many conversational turns, these chatbots are actually responding safely and maintaining the information that they need, I think is certainly something that the clinically oriented chatbots are going to have to do. But even in the things that we're doing at Create, which are a little bit, they're not direct to consumer without a therapist in the loop. But, we are trying to look at how to make sure that we are coaching therapists to respond safely. And that we're making sure that we're sort of detecting, or identifying places where maybe they need to ask more questions, et cetera. So some of our simulated patient scenarios will be things around, suicide risk going up while someone's engaged in the therapy, et cetera, so that we can be coaching them on how to handle that safely, when and whether they might need to depart from the protocol, when safety planning might be appropriate, et cetera.
I personally had not thought of that point about sort of the time span, and sort of how salient that could be of how, as humans, sometimes we remember nothing besides what we ate for lunch. Not even yesterday, we can't go that far back. But do you think that's feasible? That'll come I would say in our lifetime, but probably by next month, that will be something, right? And are people working towards that time horizon that you're describing?
Yeah, I think they are. I mean, first of all, the context window for the chatbots actually expanded so much between when we actually put in the grant proposal and when we
Hmm.
got the grant. And that will continue to happen. But there are different things you know, that can be done to sort of build in ways to retain the key information. And so, yeah, so that can be built in, particularly, I think, for a special purpose LLM. But I think we'll actually also see that the more general purpose ones get better and better at that. If you think about some of the ways that they're being developed, like these sort of co-work applications and things where they're starting to work with more and more of your files or um, I think they are already being built to be able to kind of retain a lot of information. So some of it is making sure that, they recognize the key information, respond appropriately, synthesize appropriately, et cetera. So I think when we get out to the direct to consumer piece, that's going to be really critical.
So here's a provocative one. Any thoughts, or what are your thoughts on the risk of support tools leading to de-skilling of therapists? We've seen some mixed anecdotal evidence of this in undergraduates and students' use of these.
Yeah. I mean, I think it's a good question because I mean, I think the landscape of therapy is going to change. I think with the regulatory issues that we're dealing with, it's actually going to be quite a long time before we would see, you know, regulatory issues and sort of the state of the technology. I think we're a ways away from therapists being sort of out of decommissioned, although the way we do therapy might change. But I do think that, would we have worried about de-skilling of therapists if everybody could have gotten a fidelity assessment and gotten feedback, after 50% of their sessions or 20% of their sessions? Probably not. We'd probably be saying, well, this is a great quality improvement approach. And, don't we feel like, you know, people who get clinical supervision when in training and they get a lot and their therapist, their supervisors listen to a lot of their tape, I think feel really fortunate. And we do have so much evidence that the de-skilling in terms of, the evidence-based treatments happens naturally. Like, the things do kind of decrease over time, particularly, if you've only been trained, you've seen two training cases and then you're out on your own. It's not surprising that over time, you just wouldn't, that your ability to do the intervention well without additional support might decrease. So I think that, but I think that there are ways that we can develop them so that they, and this is one of the reasons that we're attending to some of these mechanisms like, reflecting and planning and conceptualizing and experimenting, because we want people to continue to use their critical thinking. We don't want it to just be like, next session, do this, this, and this. We want people to understand why they would. We want them bringing in their conceptualization skills. So I think that the way that it happens is going to be important. There have been some, and I think there continue to be some studies with people who are, counselors on hotlines and chat lines and things like that, whether the large language models are providing suggested next steps in conversation. And the idea is that the counselor would review that and then they could tailor it or they could send it or they could not send it. I think that might provide us some of the first data on whether actually, people lose skills over the time or whether that actually supports, oh, it's suggesting something like this. I hadn't thought of that, but oh, this person responded so much better, when I sent that. So I think we have a lot to learn. It's possible that it could lead to de-skilling, but I think it's also possible that it could be a support tool that could help people really reflect and get a lot more feedback and guidance at really critical times. So, we'll have to see.
That's awesome. Um, Two questions that also kind of go together. How do you feel about the possibility of digital mental health tools being the primary way of getting therapy? So this is the first line of care instead of seeing a human therapist first. And as AI becomes more sophisticated, do you view it as a co-therapist that supports practice, as an alternative altogether? So I felt like these two questions kind of go actually hand in hand in some ways.
Yeah. I mean, This is interesting because I think, we can think a lot about, well, what do we think it can do and how do we think it would be best? How do we think it should happen? And that is important. And in the meantime, people are logging on to, ChatGPT or Gemini or whatever they use and voting with their feet, so to speak. And, that's sometimes because of things like access, stigma, convenience. So, so I think, I do think that just like we think a lot about stepped care, we think about web-based interventions and mobile apps and what they can and can't do. In some ways, I think this is not super different in that if people can get what they need from a safe chatbot. And that means that there is more availability of, clinicians who can work with people with more complex issues. Those folks can get in faster, they can see people faster. I think that could be a good thing. If people are using it and it's not actually helping and it's harming, obviously that's a different issue and one that might be really challenging to deal with because regulating and saying, okay, you've got to lock these things down so they won't talk about mental health is you know it's difficult to figure out exactly how that would happen. But I think the reality is we need to be thinking about what it is that the end users are needing and responding to. We need to be providing, really good evaluation, of, not just effectiveness and safety, although certainly those things, but all of those things we talked about in the Ready framework, so that, we can be providing some guidance to the FDA and to consumers so they know what they're getting and they're not getting. Um, because I do think that there are ways that AI can really support therapists in ways that are much more scalable. And that, I don't know if it's a co-therapist or a consultant or a medical scribe or, where the sweet spot's going to end up being. But there are definitely ways that it can provide support. But I think we also need to look at what the unmet needs are that are driving people to these chatbots and be responsive of those. And, whatever policies emerge around that should be informed by really good data.
Love it. Thank you. I see we are about at time. There were still tons of questions we could get to in the chat. Thank you all for your enthusiasm. Please join me in thanking Shannon for this incredible presentation today. We just such a wonderful overview. We want to remind attendees that on May 19th will be our final The Future of webinar for the 2025-26 calendar year. Join us then. This presentation will be up on our YouTube soon. Reach out to us at CBITS at Northwestern for any questions, and we'll add you to our listserv. Thank you so, so much.
Yeah, thank you for having me. And these are the types of questions that we're grappling with over at Create. So definitely feel free to check out our website or, I don't know how many webinar series people can really keep up with, but we just had one on, whether we should be doing AI therapy, whether it's technically possible. So if you're interested in these questions, definitely, stay in touch with us too. And thanks so much for having me.
Amazing. Thank you.
Thanks. Bye, everyone.